I decided I was going to be a doctor when I was about 10 years old. My father grew up dirt poor in small-town Texas during the Depression and then became a career Air Force officer. He navigated bombers in both theaters of World War II, as well as the Korean War. My mother was a registered nurse. I was an only child, a nerd who loved school, and nothing would have made them prouder than for me to become a doctor. The first doctors I met were pediatricians, so I decided I wanted to be one too. And that was the plan for many years. However, when I went to medical school and did my third-year clinical rotations, I discovered that pediatrics bored the hell out of me and that I loved doing psychiatry. When I told my parents I had decided to go into psychiatry, my mom was fine with it, since she had been working as a psychiatric nurse for a number of years. But my dad, did I tell you he was an alcoholic? Well, he flew into a rage, screaming at me that he'd always expected me to be a real doctor. I held my ground, and it was a noisy night. But the next day when he was sober, I told him, "This is my f***ing life, not yours, and I'm going to do what I f***ing want to do with it." There was no argument about it after that, because when I spoke to him man to man, he would always listen to me, as long as he was sober. In my second year of residency at San Antonio, I trained in psychiatric consultation, providing assessment and treatment of patients who were hospitalized on other medical services, but identified as having psychiatric problems. Problem solving has always been what I like most about my job, and doing consults presented me with a lot of unique problems, as well as a chance to interact with the staff and other specialties. The director of our consultation service, Dr. David Fuller, taught us that consults often arise from the complaints of the medical treatment team rather than from the patient. His contention was that there is no such thing as an inappropriate consult, which is not entirely true, but nonetheless it encouraged us to maintain a positive and helpful attitude for all these situations. Applying that philosophy worked well, and I became friends with some of the doctors. In the course of conversation, one revealed to me that psychiatrists were commonly referred to as spooks, as in, "That patient's weird, let's get a spook to look at him." I was more amused than upset, even though I knew it wasn't meant to convey any respect for my specialty. What it conveyed was the detachment from real medicine that psychiatrists frequently displayed at the time. This was around 1983. When there were still quite a few analytically oriented psychiatrists working, quirkier than most, appearing and then disappearing from the unit, leaving rather abstract assessments that were often incomprehensible to the other medical staff. It may have also reflected some hostility towards psychiatric patients, whose disruptive and self-destructive behaviors were unappreciated by staff in other specialties. At any rate, it brought home the fact that within the medical community, there were many different types of doctors, and then there were psychiatrists. Psychiatry's embrace of the biological model in the last few decades is largely attributed to the financial influence of Big Pharma. This was certainly a driving force. Not many of us would have bothered to change our clinical practice if it didn't pay to do so. But another major consideration was psychiatry's perennial status as the red-headed stepchild of medical specialties, struggling for a sense of our professional identity in the midst of real doctors dealing with more tangible clinical problems. You want evidence of this insecurity? When I lived and trained in Texas, I was a member of the Texas Psychiatric Society, a branch of the American Psychiatric Association. In 1986, after the biological revolution, the organization changed its name to the Texas Society of Psychiatric Physicians. In 2001, I moved to Maine, and since that time, the Maine Psychiatric Association has changed its name to the Maine Association of Psychiatric Physicians. In the past few decades, 13 of the 50 chapters of the APA have changed their names to include the wordings psychiatric physicians or psychiatric medical. No other medical specialty has felt the need to do this. So let's take a look at the factors that have contributed to psychiatry's obvious insecurities. First of all, there's the brain-mind. There's absolutely nothing in the body as mystifyingly complex as the human brain-mind. Its anatomical focus is the brain, an organ entirely encased in bone. Underneath the bone are layers of fibrous tissue and fluid that cushion the brain, all of which are vulnerable to infection if intruded upon. The brain itself is an array of about 100 billion nerve cells, or neurons, each with an average of 7,000 connections to its neighboring cells. Cells communicate between each other across these nerve junctions, or synapses, through the secretion of chemical messengers known as neurotransmitters. There are over 100 different neurotransmitter agents identified in the human brain, each of which may have either an excitatory or inhibitory effect on the postsynaptic neuron, depending on the receptor protein it encounters. The balance of neurotransmitters in this space is constantly adjusted through the processes of release, metabolism, and reuptake, which in turn are regulated by an elaborate feedback network incorporating input from other neurons as well. In short, the raw circuitry of the brain is microscopic, profuse, and unimaginably complex. The physiological tasks of brain cells are largely determined by their location within the brain network. So studies of brain cells in vitro, that is, outside of the body in a laboratory medium, tell us little about their psychiatric function. In order to study brain cells in the living organism and gain an accurate understanding of their function, we would have to pass a needle through the skull, then through the surrounding nerve tissue, causing irreparable damage to the brain, since neurons have very limited capacity for regeneration. This makes direct observation of living human brain tissue ethically unacceptable, and even if it wasn't, how many people would give an informed consent to participate in such a study? The other medical specialties, besides neurology and neurosurgery of course, focus on organ systems that are infinitely less complicated than the brain, more physically accessible, and able to withstand a needle biopsy without irreparable loss of function. Chemical markers associated with these systems are often measurable in the peripheral blood, unlike those of the brain. And other intrusive diagnostic procedures such as endoscopy are available as well. Access to this sort of information allows doctors to be reasonably sure of what's going on inside the patient, a feeling dreadfully unfamiliar to any prudent psychiatrist. And then, there is the conundrum of this organ system's duality, the brain in the physical world, the mind in the ethereal. As I explore in another video, it's entirely reasonable to assume that the mind functions much like the software in a computer, a body of information coded to create virtual machines, which in turn process information from the environment and act upon the environment. I believe that the secrets of the brain-mind constitute a last frontier of science far more daunting than astrophysics, which, after all, is just the study of a bunch of dumb particles that happen to be very far away. In the realm of medical science, the mind stands out as a uniquely remote wonder, a bottomless enigma that we haven't even begun to crack. If this wasn't enough to justify our insecurity, there's the historical fact that once a psychiatric disease does become treatable, it's usually reclassified as a non-psychiatric disease. In the 19th century, a large proportion of asylum inmates were diagnosed with general paralysis of the insane, or GPI, a psychiatric disease characterized by manic symptoms or other behavioral problems, followed thereafter by the onset of dementia and paralysis. It was noted that this presentation was more frequent in men, especially those with debauched lifestyles. Eventually, this problem was identified as neurosyphilis, an advanced stage of the once common venereal disease known as syphilis, that takes 10 years or more to manifest itself in infected individuals. Once antibiotic treatments were developed, it became a medical illness, and thus no longer the concern of psychiatrists. Similar paths were followed by epilepsy, thiamine deficiency, hepatic encephalopathy, Parkinson's disease, Huntington's chorea, and other neurodegenerative diseases. It seems that psychiatry is in part defined by its futility, since any disease that can be readily treated then becomes someone else's responsibility. This sequence of events pretty much dooms us to clinical failure, which is a pretty damn demoralizing state of affairs. Small wonder we have an insecurity complex, right? And finally, there's psychiatry's history. Psychiatry is so ashamed of its history that it's deleted much of it. The reasons we've done so are complicated enough to warrant a book of academic essays published in 1994 on that very subject. But the quacks, fools, weirdos, and even criminals that litter our history are reason enough. With our tenuous foothold on medical legitimacy, it's natural to feel insecure about a history that documents how time and time again we psychiatrists have underestimated our scientific challenges and overplayed our clinical hand. Since the onslaught of this biological revolution, with lots of pills to prescribe and dazzling new technologies, psychiatrists look and talk more like doctors now. And it seems that it's finally earned us that seat at the cool kids table. The new technologies are promising, and some of the resultant treatments are certainly better than the old ones. But it's foolish to overlook our historic tendency to overreach, to bend scientific facts to suit our will, or to discount the likelihood that our current dogma is just the latest manifestation of that same damn pattern. I believe that it is indeed happening again, and my mission, regrettably, calls on me to do whatever I can to make psychiatry less damn sure of itself.